And good morning, everyone. Welcome to the Penn State College of Medicine COVID-19 Echo Series. We're delighted to have you join us for another session. My name is Jackie Sable. I'm a member of the Echo team, and I'll be facilitating today's session. A few announcements before we begin. If you've not already done so, please put your name, email address, and affiliation in the chat box. Please stay muted unless you are speaking. You can use *6 on your phone to mute and unmute, or you can use the microphone icon on the bottom left-hand corner of your screen if you're on a computer. You may also use the chat for communicating. We realize that question and answer time is very important, and we try to categorize and address as many questions as possible. If you have questions that are not answered today, we encourage you to submit them as possible case discussion items for future sessions. You will always receive a link to submit a case or a discussion item in our follow-up emails. Please remember that no personally identifiable information is allowed when we're discussing cases. We are recording these sessions, and we will share all materials, including the recordings, after the session. In the spirit of all teach and all learn, we'll be on a first-name basis during our sessions. If you're new to Echo, our Echo sessions will always begin with a brief lecture followed by a case discussion. Cases could include a question or a challenge, anything that you would want to address that would be a critical component of our Echo model. We encourage you to submit cases, and they can be related to patients, preparedness policy, whatever challenge where you would like to discuss and generate discussion and ideas. For today's session, Dr. Glenn Buchberger will be discussing caring for opioid use disorder patients during the COVID-19 crisis. We'll also hear from Dr. Jignesh Sheth from the Wright Center. He'll have questions and strategies to share as part of our case discussion. During the lecture, again, please feel free to put your questions into the chat. We have a team of specialists from Penn State Online. They'll be helping to field questions. We will pause after the lecture to try to address as many as possible before we move into the case. But please remember that this is an all teach, all learn environment, so everyone can share both questions and answers. And with that, I'm going to turn things over to Glenn for our brief lecture.
Great. Thank you so much, Jackie. Good morning, everyone. My name is Glenn Buchberger. I'm an addiction medicine specialist, as well as an internist and pediatrician with Penn State Health, and also with advancement in recovery at the Pennsylvania Psychiatric Institute. I'm delighted to be electronically joined this morning by two colleagues and friends of mine, Dr. Sarah Kawasaki, who's the Director of Addiction Services at Advancement in Recovery, and is a powerhouse in the area of addiction services expansion across central Pennsylvania. If you haven't heard of her already, I'm sure that you will soon. A lot of wonderful things happening, to quote a nameless official that you may all know. And then also joined by Dr. Alexandra Zagierska, who is also a powerhouse in the area of addiction medicine, who is the past president of the Wisconsin chapter of the American Society of Addiction Medicine, as well as the current vice chair for the chapter council, as well as several other ASAM hats that I am currently forgetting. So my apologies to you, Alexandra. Thank you for all of your excellent work. At this point, I usually say hello to the Echo community, but given the interest in today's session, I think it's more properly called an Echo collective. Here I am tipping my hat as a Star Trek Next Generation dork. So with that as my preamble, for the next little while, we're going to be speaking about how we're going to take care of folks who struggle with opioid use disorder during the COVID-19 time, superimposing one epidemic on another. We have several different objectives this morning. I know that we have a very large share of folks from the addiction community, but also there are some people who come to us from primary care. So the first three objectives will really give a broad overview of opioid use disorder and how it's treated in all circumstances. This will only take a few minutes, and in those few minutes we will learn all that there is to know about opioid use disorder and its treatment. But then we'll spend the bulk of our time speaking about how to safely treat opioid use disorder remotely, which is the option that's left to us today. And then I'll talk a little bit about the regulatory environment that supports these approaches that I'm going to discuss. We have a rich library of resources that you will be able to access following the session, handouts for patients, as well as practice support documents for yourselves. All right, so for us to first understand how opioid use disorder is diagnosed, we need to have a general understanding of what constitutes addiction. There are a number of definitions available for addiction. The one that I use most frequently comes from the American Society of Addiction Medicine, which was most recently updated just about a year ago at this point, which defines addiction as a chronic disease, which, like most chronic diseases, is treatable. But in the case of this illness, particularly, is characterized by a complex interaction of genetics, environmental cues, and familial susceptibility. The disorder is characterized by compulsive behavior with a final common end pathway of pathologically pursuing a substance, or in some cases, a behavior. And I would stress the text in red that we do know that prevention and treatment for this disease are as successful as they are for other chronic diseases, but it does require a long-term approach rather than episodic care. All right, so that's the framework for addiction in general. How does this apply to opioid use disorder in particular? Well, we know this is a complex brain disorder characterized by disordering of the reward pathway, which involves areas of the subcortex, including the ventral striate, ventral tegmental area, and then miswiring of the emotional control centers in the amygdala, and then in turn miswiring of the decision centers of the prefrontal cortex. So that's all out of neuroanatomy, which of course we can't look directly at. Fortunately, opioid use, well, not fortunately, but for diagnostic purposes, fortunately, the final common pathways of opioid use disorder result in characterizable behaviors, which we've cataloged in the DSM-5 criteria. These are 11 criteria spanning 4 different domains. I'm not going to go through all the criteria. The domains to consider include behaviors related to loss of control, changes in social behavior leading to social problems, risky use of a substance, an opioid substance, and then pharmacologic problems. We recognize that those folks having 2 to 3 criteria over a 12-month period are suffering from a mild opioid use disorder. Those meeting 4 to 5 criteria over the last 12 months meet moderate use criteria, and those meeting greater than 5, 6 and above qualify as having a severe opioid use disorder. And in this case, the term addiction is an appropriate term. So that's a brief description of the disorder and its neurologic underpinnings. How common is it? Nobody on this meeting is going to be surprised to be reminded of these statistics. We know that in the most recent year for which we have data, 2018, really greater than 70,000 people died either directly from an opioid overdose or a combination overdose, a polysubstance overdose. The numbers concerning the number of people diagnosed with opioid use disorder, 2 million is quoted on this slide, likely underrepresents the true situation. As we're very familiar, many of these folks do not present for diagnostic workup, and even fewer present for care. Fewer than 1 in 5 folks struggling with an opioid use disorder get the care that they need. So these are the numbers of people who are affected, but how does that translate into overall morbidity and mortality? Again, not surprisingly, the rate of opioid overdose death has risen precipitously in recent years. The trend lines you'll see are beginning to flatten, and that has continued to be true, but it still continues to be true that those deaths involving an opioid still account for about 15 in 100,000 population per year. And to put that in perspective, that's rivaling deaths due to diabetes. It has exceeded the total deaths at the height of the AIDS epidemic. So unfortunately, not rare. Number of folks affected with the disease, again, not rare. And the final common and tragic endpoint of death, again, not rare. The good news, of course, is we do have effective medications to treat opioid use disorder. And prior to the current epidemic, there were some signs of hope. We have 3 different medications that are approved by the FDA to treat opioid use disorder. And these are shown on this chart here. The first 2 medications to discuss are methadone and buprenorphine. As shown on this chart, we have the log dose of the medication increasing from left to right. I believe I have that right. I was an English major, not a math major, but I'm led to understand that log dose, as we increase from left to right, indicates increasing dose of the medication in question. And on the y-axis here, we see intrinsic activity at the mu opioid receptor within the central nervous system. So the first medication, the real workhorse of opioid addiction treatment, is methadone, which is indicated on the chart, is a full agonist at the mu opioid receptor. This is a very appealing option for folks with severe opioid use disorder or folks who've required particularly high opioid doses, either through heroin or for particularly high need of prescription opioid pills. Buprenorphine, by contrast, is a partial agonist at the mu opioid receptor. This means that it's very often not a great choice for somebody requiring high doses of replacement, but because it has a ceiling effect at the intrinsic activity at the mu receptor, it does provide a great deal of protection against respiratory suppression and death, in contrast to methadone, which, if we crank it high enough up, does reach full activity and can cause respiratory suppression and death. Both of these medications have been shown effective in preventing relapse, in improving retention and treatment, and are so important that the WHO has considered these medications to be essential medicines, which means that they must be available to all members of the population in sufficient quantity, in forms that are acceptable to the population to treat those who are affected. The orphan child at the bottom of the chart that I haven't mentioned yet is naltrexone. The reason I'm leaving it for last is very good reason. The effectiveness of naltrexone really cannot measure up to methadone and buprenorphine. It is an antagonist at the mu receptor, whereas methadone and buprenorphine provide a replacement of the missing opioid activity in folks struggling with opioid use disorder. Naltrexone completely blocks any opioid activity. The way that is thought to work over time is by a behavioral unlearning phenomenon, rather than through replacement of the opioids. So these folks are not protected from cravings, and particularly in the early stage of treatment with naltrexone, folks may be at vastly increased risk for relapse and death. The good news, though, is the agonists and partial agonists do work. This is data from the primary care literature showing that over 1 year of following, people are retained in treatment at a rate roughly comparable to retention in treatment with antihypertensive management over time. When you consider that up to 40 to 60%, depending on what case series you look at, of folks who are being treated for hypertension don't take their meds, these numbers are actually pretty comparable to most other chronic diseases. Now, retention is our one of our chief measures of success in addiction medicine, but what we're really after is, do these medicines save lives? And in fact, they do. These are some older studies, but on the left, from just south of us here in central Pennsylvania, Baltimore, Maryland, we see the decreasing death rate as folks were started on methadone or buprenorphine treatment. And then on the right, we see a study out of France showing that as prevalence of treatment with buprenorphine in the community increased, the numbers of deaths decreased. So these medicines do work, but these medicines are prescribed under carefully controlled circumstances. We're seeing these folks frequently. We're checking their urine. We're checking to make sure that the amount of medication they have left partway through their prescription is appropriate. This is a potentially lethal disease. It requires careful follow-up. It requires in-person follow-up. So what are we to do in the current situation? So that's what we're going to spend the bulk of our time now to discuss, describing how to safely treat opioid use disorder remotely. My recommendations this morning will fall into two categories: those recommendations that apply to all of us, so those who are engaged in office-based addiction treatment, primarily with buprenorphine, usually in primary care settings, and those of us who are practicing an opioid treatment program. So these are the carefully federally regulated programs that provide daily dispensing medication, including buprenorphine and methadone. The main tool we're going to be discussing is telemedicine. This is electronic communication, typically includes video with two-way communication. There are a variety of platforms available, which I will touch on briefly later. Before the epidemic, and I should pull myself back for a moment, you know, I'm mixing my terms here. We've always referred to the opioid overdose phenomenon as an epidemic, which indeed it is, but I'll refer to it as the pre-existing scourge, which we now have this second epidemic of COVID-19 superimposed onto. So before the COVID epidemic, telemedicine was used primarily for follow-up visits, consultation with specialists who weren't available in the area, medication follow-ups, and really to bridge geographic divides in particularly large rural states. But now during the COVID epidemic, we're using this much more broadly, and it does have a role in opioid use disorder care. All right, so bearing in mind that buprenorphine is an option for addiction treatment in all settings, I have some advice for those treating people with buprenorphine in all settings. On the upcoming slides, you will see a SAMHSA-supported stamp if what I'm talking about has been specifically endorsed by SAMHSA. If you don't see the SAMHSA-supported stamp, it's come out of my fevered imagination, or more likely some other reputable source, but just look for the SAMHSA supported. So in the first case, for folks who are treated with buprenorphine and are established patients who we did intakes on prior to the current COVID epidemic, for those patients who are judged to be clinically stable, we would consider a 28-day prescription with a refill on it. This would not have been considered before the epidemic. We want to be calling in these prescriptions or electronically prescribing where we can, rather than a paper pickup. Anything we can do to limit the number of human-human interactions is a way to decrease infections. We want to provide telemedicine via telehealth if we can, and this is a relatively new development within the last 48 to 72 hours. Telephonic check-ins are acceptable, and the DEA actually also agrees with this perspective. For those patients deemed to be less stable on their buprenorphine maintenance, consider just a 14-day prescription with a check-in via telehealth. What about new patients who are going to be induced on buprenorphine? Can we still do this via telemedicine? It's certainly not ideal, but it is possible. And the steps to follow will look very familiar to everybody on this call. It's really the same process that we go through when we're doing an induction with buprenorphine, but with some important differences. We're going to be collecting the history. That can be done by voice. Physical exam actually is possible to an extent with video. We can document a good general exam. We can do a skin exam insofar as the patient has skin exposed. We can certainly assess their respiratory status. We can make some comments on their perfusion. And we really can do essentially an entire psychiatric exam, all of which can be documented. We want to be checking the PDMP. In this case, we might possibly be treating patients from across state lines because we're using teleplatforms, so make sure that we're looking at PDMPs for all involved states, not just our own. We still want to be collecting urines, but when we are able, that may be a good deal in the future at this point. And then we want to give the patient careful counseling about how to do home induction. So you need to have forms that you can give to the patient, either via email or by discussing it with the patient over the video link. And then, as you would be anyway, you want to be available by phone to answer any questions if the home induction does not work well. And incidentally, one of the resources that I have is a patient handout for home induction that will be available to you all after the session. And as we do anyway, we want to prescribe naloxone for all patients. And if family members can be on the video link with you, giving instruction to the family members as well. We want to consider comfort medications, as you're all very familiar. When going from full agonists in an abuse setting to a partial agonist with high affinity in the treatment setting, there is the chance for precipitated withdrawal. You want to have comfort medications available. And we want to give short prescriptions at first, as usual. Now, the uncomfortable subject that we're all struggling with, and there aren't any perfect answers here, is what do we do without urine drug screens? This is really the mainstay of assessing for how somebody is progressing in treatment. Favorable urines, we typically will space out appointments, maybe back off on our treatment intensity. Unfavorable urines, we are increasing our treatment intensity, maybe changing the dose or form of medications. And without urines, yes, we are running some risks. We might be missing diversion. We might be missing relapses. We might be missing poor adherence. But I would give everyone one note of optimism here, one note of hope. We do know that much of diverted buprenorphine is used to self-manage withdrawal in folks who can't get into care. So I'm absolutely not saying that I am in favor of buprenorphine being diverted. If we have clear evidence of it, we must do what we can to stop it. But diverted buprenorphine does not kill people as diverted oxycodone does, for example. So just to bear that in mind. But the good news is there are some ways to mitigate the risks that are created by this situation. You want to give very careful education to the patient on the risks of overdose, particularly combining buprenorphine with benzodiazepines or alcohol. And in that setting, reminding the patient that most of the respiratory protective effect of buprenorphine is lost. We want to be limiting the prescriptions, particularly early in treatment, just as we normally would. And we want to be prescribing Narcan, as I mentioned before. Now, there actually are options that might make it possible over the video link to assess for people's success in treatment. There are several different self-contained platforms that allow for salivary testing at home. These kits, when bought in bulk, typically cost $5 to $10 each. The patient can be observed over the video, placing the sponge in the mouth. That's the white cylinder pictured in the lower right-hand portion of the screen. The cylinder is placed in the mouth for 3 to 5 minutes. Once that's done, there's a plastic top that can be flipped up on this device. The sponge is inserted. There is a slot that the sponge goes into. The patient presses down on the top of the collection apparatus and then snaps shut the lid. And you get results in a couple of minutes. You will all be familiar with the readout that is available on these POC salivary testing options. It looks exactly the same as the POC testing cups that we're all familiar with. So if the patient is in frame the entire time, you could, in theory, watch them give the saliva sample, watch them develop the test, and give immediate feedback about how they're progressing in treatment. All right, now I'm going to provide some advice that is specific for the opioid treatment program. So these are the programs that treat folks with addiction using daily dose methadone and daily dose buprenorphine, in addition to take-home medication options. And I'm going to spend a lot of time talking about take-homes because this is one of the main sticking points for the opioid treatment programs. So this position, again, is endorsed by SAMHSA, and guidance that came out on March 29th recommended that those patients who are stable in treatment could be considered for 28 days worth of take-homes. So in other words, being given 28 days worth of their maintenance medicine, typically methadone. Less stable patients should be considered for 14 days of methadone. This guidance applies to all states, but I would caution you to check with your controlling authority with jurisdiction over OTPs, because there is some variation from state to state. And I'll provide some specifics for Pennsylvania because when I checked our participants, the lion's share of participants are still Pennsylvania participants, but there may be some variability across the country. This guidance remains in effect throughout the emergency. And I would emphasize again that there is some risk in this strategy, but we're trying to balance the risks of the high known mortality of COVID-19, and considering the fact that many of our patients have significant comorbidities that place them at high risk should they become infected with COVID-19, we're balancing that against the known risks of overdose and relapse. All right, so I mentioned before the idea of deciding who gets the 28 days of take-homes versus 14 days of take-homes. Here are some thoughts from SAMHSA about different categories of people to consider in each category. For those folks who are laboratory confirmed or with high suspicion for COVID-19, and that latter category is actually going to be the majority given the limitations that we have on testing currently. These are the folks who should be kept out of the methadone clinic as much as possible. So in most cases, these folks should be given larger supplies of take-homes. And if that's not an option due to instability, they should have individual reporting times so that the risks to other patients and clients can be minimized. Those who've already earned one take-home. So these are folks who have been progressing well in their treatment with favorable urines, who are meeting their counseling requirements in their opioid treatment program. These folks should be considered for 28 days worth of take-homes because they've already shown a great deal of progress with their chronic illness. We should also give priority to those of advanced age or comorbidities. Again, these are going to be the folks at higher risk for a bad outcome with COVID-19. A bit of a gray area are those patients who have one typically unearned take home. For example, if your OTP is closed on Sunday, as is ours, Advancement in Recovery, that take home was given automatically. So these folks need to be considered on a case-by-case basis, taking into account recent urine drug screening before the crisis began, reports from counselors, et cetera. And then for those patients who we deem to be clinically unstable, who are otherwise medically well from a COVID perspective, these are going to be folks that really do need to continue coming in on their regular dosing schedule. And we can work on ways to cohort patients, maybe given one take home and have them come in the next day, and thereby reduce the population who's frequently dosing by half day to day. But there will be some folks who do need to maintain their regular dosing schedule because their risk of relapse, overdose, and death is simply unacceptably high, and likely higher than that posed by COVID. All right, so for those in the opioid treatment programs dispensing methadone, for which patients can we use telemedicine? And again, this guidance comes from SAMHSA. So for those patients who are established, so those who are getting daily dosed methadone, or daily dosed buprenorphine, we can do check-ins via telemedicine. The number of take-homes may limit our flexibility to not have these folks come to clinic, but we can do telemedicine for both treatment modalities for established patients. Now, for new patients, OTPs, just as primary care settings, are permitted to do new inductions via telephone or telemedicine. But this is an important distinction for opioid treatment programs who provide daily dosed methadone. We cannot do new inductions by phone. And that makes good sense because if we're not seeing these folks in person, if we're not doing the full assessment in person, we won't have a mechanism to increase their methadone dose by the usual induction protocol. So these folks would likely be stuck at the introductory 30 milligram dose, which would actually place them at high risk for relapse and death by maintaining them on a subtherapeutic level of methadone. So again, these folks, new methadone patients at OTPs, do need to be seen in person even throughout the crisis, and I think that makes good medical sense. At some of our opioid treatment programs, we use mid-levels nurse practitioners, for example, to provide ongoing care, and also under supervision, induction, including induction with methadone. The current guidance is that direct supervision does not need to be provided to mid-levels during the current emergency, but those mid-levels still do have to have all of the usual licensure and registration, both at the federal and state levels. And it's important to note for the medical directors out there, this does not negate the responsibility to oversee all aspects of the OTP. Why is this guidance here? This gets at the potential problem of the medical director being incapacitated herself due to COVID infection, but then would permit the OTP to continue to function in the absence of its medical director. All right. So that's advice pertaining across all settings who are treating folks for opioid use disorder. I have a few more specific comments about some of the regulatory underpinnings that weren't directly pertinent to the nuts and bolts topics that I just discussed. I suspect many of us have some concerns about how privacy will be protected with the changes, and how we will be covered from a HIPAA standpoint or from a 42 CFR standpoint, Part 2. So guidance that came out from the Office of Civil Rights at the Department of Health and Human Services has decided to exercise its enforcement discretion over HIPAA, potential HIPAA privacy violations in the context of telemedicine. This has immediate effect, and during the emergency, if we elect to use telemedicine, we are permitted to use non-public facing, non-HIPAA compliant platforms for video conferencing. So these are just examples. There are others, but these include such platforms as Apple FaceTime, Google Hangouts, Skype, The key distinguishing feature is all of these services involve two-way communication between people at 2 points. The discussions are not posted online. The discussions would not be available to social media. Now, it is very important that we still warn the patient that the communication going back and forth may not be secure, that we can't guarantee it as we normally would, but these are acceptable options, and in the event of a lapse of privacy, the Office of Civil Rights will not take action against programs operating in good faith. Now, that said, this does not apply, this is not a blanket permission to use any two-way video platforms. Those platforms that are non-HIPAA compliant and that are public-facing are still prohibited under this period of time. So Facebook Live, Twitch, and TikTok, these platforms cannot be used for this purpose. I don't think that I would actually be able to find TikTok. My only exposure to TikTok was the hygiene hamster as featured on the last episode of John Oliver's Last Week Tonight before he went off the air. But anyway, this would not be an appropriate medical forum and would not be protected under the suspension. So do not use these platforms. So those of you who are practicing in opioid treatment programs, the privacy restrictions go one step further under 42 CFR Part 2, as we're all familiar. This set of regulations really does present, under normal circumstances, a consent challenge when using telemedicine, because typically we require an in-person discussion, we require signing of forms for release of information, but SAMHSA has provided some guidance saying that during an emergency, a bona fide emergency, information can be released without obtaining consent from the treated person first. And now I'll use Pennsylvania as an example because that language can be a little bit confusing for someone like me without a legal brain. Our Department of Drug and Alcohol Programs has, in conjunction with SAMHSA, learned that the current pandemic does constitute an emergency, and that as long as treating providers are operating in good faith, they can use the aforementioned platforms without fear of retribution. So you're protected by state and federal regulation during the emergency. Some of you might be wondering about the implications of the Riot-Hate Act. This Online Pharmacy Consumer Protection Act of 2008 was designed to protect people from receiving prescriptions for controlled substances without having had an in-person visit. I'm sorry, Ryan Haight, you're gonna have to wait in the corner for a while. Under the circumstances of the public health emergency, portions of this act have been suspended, and the DEA has given guidance in this area as well. We are permitted to provide prescriptions for controlled substances without an in-person visit, and that does include Schedule III medication, i.e. buprenorphine, to be used for opioid use disorder treatment. The public health emergency, which was declared retroactive to January 27th, 2020, covers these acceptable uses. Now, just to make this a little bit more specific, what are the conditions that you have to meet to issue a prescription for a controlled substance, including buprenorphine via telemedicine without an in-person visit? Well, you must be able to show that the prescription is for a legitimate medical purpose, and addiction treatment now, thanks to the DEA's clarification, opioid use disorder treatment does qualify. It must involve audio-visual, two-way, and real-time communication, but the DEA did clarify a couple of days ago that telephone, while certainly not preferred, and the language in the announcement tells all. I suspect the director couldn't believe that he was writing the words that he did, but that telephone would be acceptable under the current emergency. And you want to make sure that you're complying with all applicable laws at the state and federal level otherwise. So I just wanted to provide in closing an example of how some of these regulatory changes have come together in my adopted state of Pennsylvania. back in 2018, the legislature adopted an act that required controlled substance prescriptions to be sent electronically, which made good sense. It was a good upgrade in security in most instances. But under the current emergency, it has been decided that we are able to send the prescriptions via phone or via paper to limit the possible exposure of infected people or of uninfected people to potentially infected people or surfaces rather. The requirement, though, is that the prescriber has to reasonably determine that electronic prescribing would be unsafe. But again, as I mentioned a few slides ago, the state has determined that the current situation does constitute an emergency under which these regulations can be suspended. And a couple of other recent developments, an information bulletin which came out on March 18th said that the single county authorities operating under the Department of Drug and Alcohol programs could actually use funds to support not only medical services, but counseling services in treatment of folks with addiction. I mean, as we know, counseling services are critical for ensuring long-term recovery with this disease. And again, I want to emphasize that two-way audiovisual communication is preferred, but if the only option is telephone, that is acceptable. We also had guidance on the 18th, and this pertained to opioid treatment programs, that a portion of the PA code was suspended that typically pretty strictly limits the maximum number of take-homes in our state. Under most normal circumstances, take-homes are limited here in Pennsylvania to no more than 6. That rule has been suspended. It has gotten out of the way for SAMHSA to allow us to potentially give 28 days worth of take-homes, as I mentioned in the previous slides. So it's a lot of information to digest, a lot of changes coming at us very quickly. As I mentioned, the DEA changes just went into effect 72 hours ago. So, check back next week. This presentation might look completely different if it was to be given then. But I do have some references here that you can certainly consult. We will make these slides available. And as I said before, I have a number of references for patient handouts, practice workflows, and then also some evidence support. So thank you so much. It was delightful to join you all this morning, and I'll look forward to our ongoing discussion for the rest of the hour.
Thank you, Glenn. We have right now a question and a comment in the chat. So Jenna asked, is there a concern or any concern with the use of Google Voice regarding HIPAA compliant communication? Generally, they are using that to text the patient the link for the Zoom from their office.
Okay.
I'm going to also put that out for anyone else who may have information on that.
Sure. That's a great question. I would be speculating in making this answer. I don't know enough about the security of Google Voice to be able to comment specifically. I suspect that would be permissible, and I will also ask my colleagues if they have further thoughts about that.
And while we're waiting, if anyone has thoughts on that, there was a comment that I'd like to share for those
So
who...
Jackie, this is Dr. Shet. Google Voice is just similar to any voice over IP service that we would use. And the privacy will be the same as using a Skype or any other service. It's voice over IP, so it should be fine.
Okay, so that would be covered under the current guidance then. Thank you.
Mm-hmm.
Thank you, and don't go too far. We're going to pull, Jignesh, we're going to pull your slides up shortly.
Good to see you again, Dr. Sheth.
We have one comment. Kay Cohen says the preferred term for PAs and NPs is advanced practice provider. The ANA has just issued a statement coming out against the use of PAs and NP terms. So just as
very good.
Our chat.
Advanced practice providers.
Yes. Okay, and then Danielle mentions that they're doing individual sessions through telehealth, but what's the recommendation about running groups if you can only use the phone?
Yeah, okay, great question. So yes, groups should be generally limited to no more than 5 people. And as a practical matter, during the duration of the emergency, it would be best to use telemedicine for individual sessions whenever possible.
Okay, thank you. Please continue to put your questions in the chat. We'll continue to monitor them, but I want to turn it over to Jignesh from the Wright Center, who has more questions for us and also some more strategies to share. And I believe Erica will be advancing slides for you.
Okay. Well, thank you. That I have to tell you, Doctor, that was an excellent presentation. It has been a while since I heard about all these principles, and I too have to say that was excellent and really sets the stage for things that I would like to discuss. I don't have as well as uh, prepared slides as you, but I will try to start a discussion here that all of us can participate, and hopefully we can share what we have been doing in our individual practices. So this is Dr. Jignesh Sheth. I am the Chief Medical Officer at the Wright Center here in Lackawanna and Luzerne counties. I am board certified in both internal medicine as well as addiction medicine, along with my colleagues here, Dr. Linda Thomas, who's the CEO of the Wright Center, as well as Dr. Jumi Burwal, who's also the one of the participants here. I know she is on the call. So we at the Wright Center have worked on preparing ourselves as an essential community provider in the past year or so. So about a year ago, we started this journey to apply at the federal level to be an essential community provider. So a lot of things that I'm discussing today were things that were already sort of in place or things that we had thought about in the past to be prepared in case there is a need for us to come in really and function as an essential community provider. So I would like to jump right into the questions that Jackie shared with me in order to start sort of a discussion at high level as to what practices are doing or could be doing in order to treat not just OUD patients, but any patient during the COVID-19 crisis, but it specifically does apply to OUD patients because of the complexity of, requiring a lab test, a prescription every 2 weeks. There is a higher level of complexity than your usual medical patients. So the first question really that we wanted to highlight is, how are providers continuing to treat patients with OUD during the COVID-19 crisis? So this is what we are doing at the Wright Center. Physician visits for opioid use disorder patients have been reduced to every 2 weeks. We have usually seen patients every 2 weeks by the providers. That's the rule. And then in the alternate weeks, when they're not seeing the physician, they'll be seeing a case manager. So essentially what we have done is in the past, we would have the patient see a physician or a provider like a nurse practitioner or a PA alternating with a case manager. So there will be a touch point every week for any patient who's in the treatment program. What we have done is we have kind of relaxed the requirement to every 2 weeks, but we have made it tele, e-visit, and virtual visit compatible. And that's a big step because obviously these are high-risk patients, but we also realize that this is high-risk time. So these are times when the stress level is high, patients have issues not having a job, not having food, not having daily supplies, and these are times when there will be the highest risk of relapse. So in order to counter that risk, what we decided to do is implement telehealth, e-visits, and virtual visits. And they're all different, and I'll kind of briefly give an overview of what that means. But before we even go into that, I want to go into my second bullet, which is the consent. There has been conflicting messages around consent. Can you take a verbal consent? Do you need a written consent? How do you send out the consent? And there has been no clear way of sending out the consents. So one of the things we did is we looked at all the best practices around the area from ACP, AAP, American Medical Association. And the one thing we found is either verbal or written, a consent has to be obtained in most cases prior to these visits. One of the other reasons that it's important to obtain consent is a lot of the insurances are applying billing for these visits towards patients' deductible. So the last thing you want is patient gets a bill and the patient never consented to it. And in the bigger scheme of things, where the government is saying that a lot of this will be paid, there is a lack of clarity at the local insurance levels of what is covered versus what is not. And even when we call CMS, and in 3 different calls, we got 3 different answers. And we were calling the same 1-800 number. So the problem is there is confusion at the level of federal government. There's confusion definitely at the level of state. And one thing we did not want to do is um, make our patients, unaware that there is a potential that some of these costs will be transferred to their deductible. So in order to be clear and upfront with our patients, we created the consent. The second challenge, obviously, was how do you send this consent out? Luckily, we have been collecting patients' cell phone number as well as email addresses over the past several years as one of the meaningful use requirements. And one of the drives we had at the Wright Center was also to activate people on patient portal, which obviously requires you to have an email address. So we have been collecting traditionally this information. We signed up with a HIPAA compliant e-signature software. In my organization, we are using Zoho, but I mean Zoho, DocuSign, Adobe Signature. They're all HIPAA compliant ways of obtaining electronic or digital signature. The advantage of these products is they all allow you to sign right from your cell phone or from your computer. So we created a signature template, a consent template in one of those softwares that can send it out in mass to the patients that we have to get the consent from. And we made this as part of pre-visit planning. So generally, when a patient comes in for an office visit, the medical assistant does pre-visit planning the day before and makes sure that they go through a list of things the patient's going to require when they come in for the visit the following day. In order to mimic the same process, we made sure that the MA, as part of pre-visit planning for a televisit, will ensure that the consent for that visit is in chart a day prior. The consent is actually sent to the patient at the time when the appointment is made. On several locations, it's the same day. But when the front desk is making the appointment, we have trained them to send the consent, because we have put that link on their sidebar so they can quickly send the consent over to the patient. And then we have made that a responsibility of the front desk to educate the patient, but also the medical assistant who does pre-visit planning to obtain the consent before the visit. Now, I can tell you this is not a perfect system, because there has been times when I jump into the call and there is no consent. Depending on my level of comfort with the patient, I have had patients who would say, Doc, I'm just going to send it right away. I know we are already on the call. Let's discuss the case. I will obtain a verbal consent there with a clear understanding the patient will be sending the consent back. And that has never been a problem. Patients are very understanding. They're actually very thankful that they are able to do a visit over the computer or over their cell phones without having to come into the office. And I've not had any pushback on getting the consent signed. We are making it clear to the patients if they don't consent, we are unable to continue with this visit, and we've been requesting the patients to come in. I would say I've had 2 patients who declined to sign the consent. Some of them were worried about that being paid. Some of them were worried about not having enough information about what this means. And we are allowing them to come in to the office, because if they're really not consenting to it, we shouldn't be doing the visit. So that was a challenge to set up. As you can imagine, it wasn't easy. It sounds easy now, but setting up the account and making sure it's HIPAA compliant, and creating the templates and making an automated process, because eventually when the signature page does come back, you have to download it as a PDF from the software and upload it to your chart in order to be compliant. So there are numerous steps involved, but the first step I would say is create the consent, put it in a HIPAA compliant electronic signature form, send it out to the patient, and have a process in place that when it comes back, whoever gets the notification that the consent is back downloads the consent and puts that into the chart. And making that a responsibility of the medical assistant as pre-visit planning really kind of close the loop, so that the physicians, PAs, NPs, whoever is doing the visit is not responsible for this. The other thing we also did is this consent covers all 3 types of visits: televisit, e-visit, as well as a virtual visit. A televisit is when both patient and providers are on a video-based software, and so you could see each other. It could be initiated by the office, or it could be initiated by the patient. E-visit is on the other end is defined as a visit that is really initiated by the patient. In our case, it is through the patient portal, and where you are messaging back and forth about an issue that the patient has, but really it's initiated by the patient. So that's the rule around e-visit. It has to be patient initiated. And the last but not the least is virtual visits, where you're having the visit over the telephone, which again could be initiated by the patient as a phone call, or when we are trying to call the patient, they are requesting a virtual visit. So that's how we have put this process in place. There are templates there are templates in our electronic health record that we specifically created around this time, so that the documentation is there of what was discussed. There are CPTs surrounding specifically virtual visits because they are time-based, so there was under 10 minutes, 10 to 20 minutes, or 20 to 30 minutes. There are CPTs around that that I'll be happy to share after the call with the participants of what we have discovered over the last 2 weeks. Telehealth visit, really, it has to be the same CPT you use for visits. Until about 2 days ago, if a practice is an FQHC or an FQLA, they were excluded by Medicare to be paid for televisit. So the general rule that came out on March 6th, that televisit will be paid at the same rate as your fee-for-service Medicare in-person visit, that did not apply to FQHCs and FQLA. They were excluded. 2 or 3 days ago, they released another ruling where that has been that they have been included now and they will be covered. Having said that, there is a lot of confusion at the local level of how this is all going to work out. But what we are doing is we are doing the televisit and using the same CPTs that you would use for in-office visits. So we have significantly increased the amount of tele e-visits and virtual visits. Really, we are focusing more on televisits and virtual visits. Virtual visits is telephonic, televisit is video, and that's how I kind of keep it simple in my head. We have created progress notes for the same in our electronic health record, so the documentation is standardized across the organization. And we have done the same application of visits at the case management level. So even my case managers are actually doing or completing their visits over the electronic platform. There are two issues surrounding seeing patients with OUD on tele platform. First, obviously, sending the scripts. Luckily, all providers at the Wright Center have access to electronic prescribing of controlled substances. And we have started doing that about 3 years ago. So we never did a paper script. So this means it makes it so much easier that the script can be directly sent to the pharmacy for the period of time that we think we can release the patient script for. Most patients are getting 2 weeks supply as a result of this COVID-19 crisis. Our usual practice is to do 1 week at a time, but during this crisis, we have extended that to 2 weeks because we know patients will face hardship in order to go to the pharmacy, pick up the medicine, as well as pharmacy hours are changed during these times. So we wanted to make sure that we do 2 weeks at a time. We are also sending the urine drug screen lab slips directly to the lab of patient's choice. The visit. So when I'm talking to the patient, I'm asking them what the nearest lab is and sending the script right over. So this way, they accomplish their urine drug testing right at the lab instead of point of care they're used to doing in the office, and the script is sent to the pharmacy electronically. So the things have been kind of put in place around that. The second slide really goes around policies and procedures that we put in place. Again, these are the same things that I went over. I mean, really creating the consent, rolling out a consent acquisition process, putting that in the electronic health record, creating an electronic form where the visits will be documented in your electronic health record. One of the things that we initially started with is designated rooms for telehealth visit. That really doesn't work. We thought that we will just use televisit as a general visit when a patient shows up in the office. So if I'm using 3 rooms during my usual practice, one of the rooms can work as a televisit because I'm carrying my own laptop into the room. One of the advantages we had with my electronic health record, which is Medent, is we started working with them about a year ago to implement telemedicine. So luckily, they have a homegrown telemedicine platform that is integrated right into the electronic health record. So for a physician, the patients will show up on my list like they always do for office visits. Instead of clicking on their visit where I open a progress note, I get a video button that I click on the video, and the visit starts right on my computer. It's a WebRTC base for folks who like the technology that they're using. And WebRTC means they're able to open the video in any browser. It does not require a specialized software, which I think is advantageous over Zoom or Cisco or whatever software you use, because most of these software require a thin client or an actual application to be installed at the patient level. And sometimes even at the provider level, or most cases at the provider level. A WebRTC-based video conferencing allows you to use just the browser, which every smart device has. So a laptop, phone, tablet, doesn't matter. As long as you have a browser, the video conference just starts. And that is very helpful because it makes it so much easier for patients where you send them a link, they click on the link from the text message, and they go right into the video. And there is no pushing of buttons, downloading of apps, putting in meeting IDs, nothing. It's integrated right with the appointment schedule. They also get reminder for their appointments, similar to other appointment reminders they get, and everything is integrated into one link. So this is making it so much seamless for our patients. One click, they're right into the conference. One click for the doctor also, they're right into the visit. And this makes it so much easier. So working with your electronic health record vendors to automate the process and integrate that right into your appointment schedule is extremely important, but that makes it seamless and less time consuming. We can go through. So what have we done in order to be prepared for this emergency? Some of the things that we have done is also offering a safe place for our patients to be seen. So we have designated areas in each clinic where patients are seen if they present with any form of respiratory illness. Why is this important? We have big signs posted in the clinics that we are doing that. We have a huge check-in desk at a point where everyone enters the building, employees and patients, so that people know that we are screening everyone at the door, offering them a mask and having them go through a different door if they have respiratory illness. What this has done is our patients feel really safe coming to the office. So even though there are many patients who do not want to do a virtual visit or a televisit, they know that it is safe to come to the office because the Wright Center has put processes in place where they feel that they will not be co-infected for most purposes because we have put plan in place. In order for my employees to feel safe and make sure that they know that, yes, we are taking every step as an organization to keep them safe, we just installed this week tents outside my building that will serve as a triage and treatment area for patients with respiratory illness. So they don't have to go into the building. Even though in the current time frame, they are entering the building through a different door, they have a designated area that is locked out and then can only be accessed to that one door. We were unable to put a negative pressure ventilation in that room because of construction constraints. The reason that we put a military tent out is because it does negative air pressure. It is outside of the building. It is attached to the building. It will serve as a triage and treatment area at one of our largest clinics that's open 7 days a week.
I'm going to interrupt here for a minute. We've had a lot of things coming in on the chat. Sarah has been providing some responses, and I just want to make sure that we've addressed everything. There were so many coming through, quite a bit around, let me see, consents and is it okay to mail? A lot of concerns regarding sending patients to the labs and the risk of that. So Sarah, do you have anything that you'd like to respond verbally with here before we move on or take any other questions?
I think that in general, what we can do is email the transcript of the chat to everybody so that they have it all in writing. There are a lot of good resources on the SAMHSA website as opposed to, with regard to billing codes for certain kinds of visits. And also for urine drug screens, really it's up to you how you want to handle that. In general, I would say overall, the idea of safe prescribing and managing opioid use disorder with social distancing, the idea is to get the stable patients out of the office so that you're making more room for the unstable patients who need to come in. So
Yep.
you can't completely suspend all visits. You actually have to see the unstable patients that they don't die of opioid use disorder. You just need to cut the traffic in half by getting the stable patients to stay put so that the unstable patients are made safer in the office.
Thank you for sharing that. And yes, we'll capture the questions and responses to those questions, and we'll make sure that they're part of the follow-up materials. We have about 2 or 3 minutes left. I wanted to see if there were any questions, or Jignesh, if you have any last closing points that you'd like to share with the group.
I just want to say I will be available to answer all the questions if you just email me them, and I'll make sure I send a response over to the group. When I do send the responses, I'll be sure to send a small table of the CPT codes that we are using. That will be helpful for all the practices. And again, whatever we can do to help, it'll be something that I'm happy to do. One thing that came up about the signatures, we found that Zoho signature was extremely easy for patients to use. So they're able to use their finger and just sign on the screen itself. It's very intuitive and simple to use. Adobe I found was a little difficult. DocuSign is pretty much similar. So Zoho and DocuSign, in my experience, this is just experience. I'm not saying one is better than the other. From a simplicity perspective, I think those two are easier software to use and navigate.
Thank you for that. And there is a quick question here from Paul. He's been having some challenges around CVS that the store will not confirm whether they carry Suboxone or have it in stock until a prescription is put in. Is there any way around this? Has anybody been seeing this, or any suggestions for that?
Yeah, so I'll just comment that CVS and other big pharmacies won't name them here, rhyme with Schmite made. Anyway, so they have a lot of difficulty in terms of, I think that there's a lot of stigma with people with opioid use disorder. I have had mixed success with them. The best thing to do is really befriend your local mom and pop pharmacy and have them carry all forms of medication that are compatible with different insurances. We've had the most success that way.
Okay, well, thank you for that. And again, in the interest of time, I'm sure we could have continued this session a lot longer, but in the interest of it is our 9 o'clock time. Just a few reminders: you are able to collect CME credits for participating today. If interested, there will be a survey following the session. Please complete one survey for each session that you attend, and you can continue to use that same link for future submissions. As mentioned earlier, we'll provide all materials via email afterwards. And finally, we hope you join us for our next ECHO session. I believe that is scheduled for tomorrow. Can somebody on my team help me out with that one, Erica?
Tomorrow morning at 8:30, and it's covering the current pandemic and public health approaches to COVID-19.
Thank you. So we hope to see you there, and we look forward to working with you in the future. Good luck and stay safe.